grand rounds that Kylie Washburn is helping us host. So I want to thank Kylie for her service to the department, and we really appreciate everything you've done with the CME office. Thanks, Kylie. Joanna, do you want to come in?
Thank you for coming today. It's my pleasure to introduce you, Emily Gale. And she was nice enough to write her bio with big letters, so I don't have to wear my reading glasses and date myself. Emily received her bachelor's degree in psychology from the University of Nebraska-Lincoln in 2006. She continued to pursue her master's degree, and now she's expecting to, she's a PhD candidate with a graduation in August of 2012. Her thesis examines affective changes in child maltreatment survivors during marital conflict. Her interests are child maltreatment, the impact of the internet on clinical practice, and clinical work with children and adolescents. She's with us in this department working on her internship in child and adolescent, with the child and adolescent division rather. Emily's it's been great to have her with us. She has a lot of psychotherapy experience with kids, adults, in substance abuse, in maltreatment. She has received awards for her research work on internet and its implications for mental health. She has published 2 papers, one in the Journal of Behavioral Therapist, another in the Training and Education in Professional Psychology. She has presented over 10 presentations in both national and international meetings. So it's a great pleasure, Emily, to hear from you this afternoon.
Okay. Thank you, Joanna, for that very kind introduction. I apologize. I sound very bad, so I'm going to try to talk as much as I can, and hopefully I'll be able to make it through the presentation without having to stop or shorten it. So I'm going to be talking today a little bit about kind of where I started in research, which is the long-term effects of child maltreatment. And really, so I'm much more clinically focused, so I wanted to spend my time talking about what we do with the survivors of child maltreatment when they come into therapy. So just to give kind of the props where they're deserved, I come from the Family Violence and Injury Lab at the University of Nebraska in Lincoln. That's directed by Dr. David DeLillo, who's my primary advisor on my dissertation and on my master's thesis. And really the mission of the Family Violence and Injury Lab is to conduct quality research on family violence that's used to inform prevention, intervention, and treatment efforts. There's a lot of us that have been through the lab over the past couple years, so there's been a lot of different aspects of child maltreatment that have been investigated. When I started in the lab as an undergraduate, which makes me feel really old, we were looking at the relationship between child maltreatment and marital outcomes, so marital satisfaction, whether or not the marriage even survived, and then how happy the people were in the marital relationships. We also were looking at intimate partner aggression and the kind of people that perpetrate that, and if there's any link to child maltreatment in the perpetration of intimate partner violence. Some of my other colleagues have investigated issues such as the linkages between early child maltreatment and adult revictimization. That's actually the new grant that my advisor has, is looking at revictimization and what predicts that over the long term. And we can talk a little bit about that if we have time at the end. There's also some of my colleagues that are looking at the relationships between emotion regulation and both physical and sexual abuse and perpetration, and then the assessment of child abuse experiences among adults. I think we've all, in our injury lab, have participated in research on how methodologically we measure child maltreatment and some of the issues that go along with that. And that could be a whole other grand round, so I won't even get into it. So let's talk a little bit about why child maltreatment is a problem, other than the obvious that you shouldn't hurt kids. So between 1993 and 1994, about 600,000 children were deemed at risk for harm from physical abuse. About a little more than a million were at risk for physical neglect, and about 500,000 were at risk for harm from emotional neglect. Just as a caveat before I jump into the sexual abuse statistics, sexual abuse is much harder to estimate. Usually we find that there's larger ranges in the rates of sexual abuse, mainly because this actual sexual abuse, I don't know if you want to call them standards or rules, vary from state to state. They also vary between researchers, so how people measure it really can range from over-the-clothes touching to obviously like childhood rape, things like that. So there's a lot of discrepancy in the literature about how many kids are actually sexually abused. However, the estimates are saying between about 200,000 and 300,000 are estimates of sexual abuse. Reports from CPS, and this is again from I think 2002, indicate a national victimization rate of 12.3 children per every 1,000 children. In 2010, the national rates of abuse, as estimated by the National Child Abuse and Neglect Data System, which is the largest report that comes out on child abuse, estimated there to be about 10 victims per 1,000 children in the U.S. Of those victims, about 78.3% were neglected, 17.6% physically abused, 9.2% sexually abused, 8.1% psychologically maltreated, and 2.4% medically maltreated. So again, some of these numbers may be an underestimate, and that's something to keep in mind as you're working with victims of child maltreatment. So we kind of know that, everybody knows kind of intuitively that maltreatment is bad, but I want to spend some time talking about some of the short-term and long-term consequences of child maltreatment. So obviously the most severe consequence that could go along with child maltreatment is child death. And over the past few years, namely the past 3 years, fatalities have increased. So in 2002, about 1,400 children were estimated to have died from some sort of child abuse or neglect. But in 2009, 1,770 children died from some sort of abuse or neglect situation. And that averages out to be about 2.34 children per 100,000 children. Head injuries are the most common cause of death in maltreated children. And of the fatalities, children under the age of 4 are the most frequent victims. In 2009, 1 year and younger were 46.2% of fatalities, and younger than age 4 were 80% of fatalities. So while the abusive acts and situations can range from minor physical injuries like bruises, they can also go to serious disfigurement and disability. There's also long-term health effects. These kids are more at risk for cancer and heart disease when they are adults. Obviously, the head injuries and the brain trauma that might go along with that. Burns, chest and abdominal injuries, fractures, growth delays, mainly from failure to thrive. Lead poisoning from neglectful environments, and failure to thrive or failure to meet developmental milestones as expected. So those are the physical consequences. Psychologically, there's a lot of research that talks about the consequences of child maltreatment. In the short term, there's obvious emotional difficulties such as depression, anxiety, and suicide attempts. But in general, maltreated children experience a variety of detrimental abuse-related outcomes, including intellectual difficulties, impaired physical, social, and psychological development. They oftentimes have impaired language development and impaired cognitive development, whether that's from TBIs or some sort of head injury or from nutritional issues, not getting enough nutrition early in life. They generally develop on a different trajectory than non-maltreated children. They also show more externalizing behaviors such as heightened oppositionality and aggression. Neglected children and, really some of the other kids who are experiencing pretty severe abuse at the hands of a parent have disruptions in attachment and various psychological factors such as self-esteem and cognitive deficits. These kids also show in the short term lots of social impairments, which can include being very dependent in relationships with peers or just being very distractible in classroom settings and difficult to manage. So obviously, many of these difficult difficulties, if not intervened upon, extend into adolescence and adulthood. So not only are they having short-term consequences, but the detrimental effects have been shown to extend into adolescence, where kids are more likely to engage in substance abuse, more likely to attempt suicide. For adults, physical abuse is linked to the increase of dating violence, as well as perpetrating violence against one's children. Now, it's not a causal link, but it's just associated. I just want to make that clear. And adults that were abused as children have greater rates of substance abuse and are 4 times more likely to experience a personality disorder in adulthood. So basically, before we get into some treatment issues, it's really important to talk about how severely childhood abuse interrupts a child's development. And understanding that will help us kind of understand some of the treatment implications that go along with this population. So intrafamilial trauma during childhood creates a burden that distracts and distorts from the achievement of typical developmental goals in the childhood and adolescent years. Highly traumatized children often are putting their energies into doing things like surviving or trying to get out of physically harmful situations, or psychological strategies that we know are maladaptive, like numbing, denial, dissociation, or distorting the meaning of an event when physical escape is not possible. So it makes sense that if they're putting their energies into those areas, it's going to be very difficult to develop on a normal trajectory. I think today, I should have said this a little earlier, I'm going to be talking mainly about sexual and physical abuse. That's where the bulk of the research studies lie as far as treating victims. However, the things that I talk about really cut across all types of abuse and even other traumatic incidences that we can talk about if we have time at the end. So for sexual or physical abuse, these 2 types of abuse really sort of disturb the development of a coherent and integrated experience of the senses and of the body. This is, it's obvious that a very immature child, immature in a physical way, I mean, they can become overwhelmed by the unmodulated, uncontrolled, and undifferentiated sensations that occur during sexual and physical abuse. Further, children are often abused by caretakers who are failing in their fundamental task in teaching children how to modulate arousal, whether that's physical or emotional arousal. So again, appropriate and effective caretakers modulate a child's emotional arousal by providing appropriate doses of soothing and stimulating activities, which maximizes comfort and security. It facilitates a child's learning of self-soothing techniques and selectively orients him or her to the external or internal environment. Caretakers ideally help a child to label their feelings. For example, when a child's feeling upset, the mother may say, "You're feeling upset because you missed your friend at school today." And by doing that, the parent is labeling the feeling, describing the experience, and explaining the source of the feeling. And that's really how we learn how to do that with social modeling. In an abusive situation, a child may get hit and then told, "That doesn't hurt. That didn't hurt you." So the child experiences a very discrepant situation between an internal experience, which was pain or however you want to describe it, and then the label that's given to it, which is, "That didn't hurt, that doesn't matter, you don't matter." As a result, the child is confused and may distrust their sensory perceptions and have a limited capacity to describe and accurately differentiate their feelings. And that's sort of a point that I'm going to be coming back to you again and again during our time today. Further, like I kind of alluded to a few minutes ago, abusive caretakers tend to be poor models of emotion modulation, as they generally have limited emotion regulation skills themselves. Parents who are abusive are significantly more likely to have drug and alcohol problems, experience mood disturbances, to have been in trouble with the law, spent time in jail, or spent time in mental health hospitals. As such, they're not likely good models of behavior or emotion modulation. Children instead observe the absence of modulation and the negative effects associated with it, like a dysfunctional family environment or legal problems. Excuse me. These problems with emotion modulation can be evident in abused children as early as the toddler years, where you see toddlers who are highly negative. They also usually have much higher rates of anger and aggression. And in preschoolers, we see a lack of self-control that would be developmentally appropriate in this age group. In older preteens and adolescents, they tend to be more impulsive, likely to engage in impulsive behaviors, including sexual activities and drug-related activities, and have a lot of reactive aggression. So they tend to be the kids that get in fights and are the ones that start the fights over seemingly small issues. In adults, we could talk all day about the research about emotion regulation, but really, usually what brings victims or survivors of child maltreatment into treatment is the problems with emotion regulation. They tend to be labeled as emotion phobic or alexithymic, as it's known now in the literature, having high levels of hostility, anxiety, depression, and problems with anger management. Child abuse also interrupts the development of agency, which is something we know a lot about in the children's literature, which kind of extends into adulthood. And agency is understanding the cause and effect that you play on the environment. This is demonstrated in kids as young as 12 months, and caretakers often play a very critical role in the development of the experience of the self as a cause of events. A caretaker often draws a child's attention to their influence in the environment, and as such, the child learns that, hey, if I need something, this caretaker is going to come help me figure this out. Conversely, a caretaker who does not kind of feed or develop a child's sense of agency by either neglecting the child's needs, being unaware of their needs, or ignoring the child's signals, such as when the child cries, the thing that they learn is that you don't matter or you don't exist to me. So the caretaker becomes a reference point for what's successful. And really what you learn in an abusive environment is that not making any noise or not doing anything is the way to be successful. But as we know, that's not a healthy way to live your life. Finally, on the interpersonal development, this incorporates the management of feelings, kind of like we've talked about just a couple seconds ago, and incorporates that into the relationships with others. And it's been found to have three key parts: learning and implementing interpersonal models for establishing relationships or schemas, learning how to resolve conflict, and developing flexibility in interpersonal expectations and behaviors. And what we know is that relationships with parents, siblings, and other caretakers create the first models for relating to others and are used as a template to guide expectations and prime behaviors in the development of relationships that follow. So obviously, abusive situations create problematic relationship patterns and attachment in children. This leads to problems throughout the span of development. In childhood, children who are victimized are associated with negative social behaviors such as peer rejection and bullying. In adolescence, they're prone to aggression, social avoidance, as well as increased delinquent behaviors and early sexual activity. And logically, adult survivors report significant interpersonal problems ranging from sensitivity to criticism, inability to hear others' points of view, and being too controlling or submissive, being inappropriately assertive, and being insufficiently sociable. So all of these sort of disruptions in development lead to rigid schemas that are applied to everyone regardless of their situation or the information presented by the other person. And the survivor ends up with the schema that if I need help, other people aren't going to help me, which leads to, again, increased feelings of depression, can exacerbate any PTSD symptoms that would be present, and really increases that sense of, like, I'm in this by myself, I'm alone. So key goals in treatment are to involve helping the survivor develop alternative ways of relating to people and developing a sensitivity to the diversity in the nature, character, and context of relationships. Okay, so the leading model for treating adult survivors was developed by Marilyn Cloytra. The most recent edition of her book, which is it's called Treating the Interrupted Life, published in 2006, and her main sort of thesis is this idea of a resource loss model. And the resource loss model is a way of defining trauma, vulnerability to trauma, its psychological consequences, and the characteristics of effective intervention. So she defines psychological trauma a little bit different from everybody else, but she has a lot of empirical support for the way that she does things. So psychological trauma by Cloytra is defined as a circumstance in which an event overwhelms or exceeds a person's capacity to protect his or her psychic well-being and integrity. So it's a collision between an event and the person's resources, where the power of the event is greater than the resources available for effective response and recovery. So the trauma is actually a very complex relationship between an event and a response. So I'm just going to kind of go through these three parts and talk a little bit more about why they're important in treatment and how they're addressed. So, psychological trauma. So child abuse represents a major trauma as the children's internal or personal resources are limited by the fact that they are little. They're little kids and they're not fully developed. So their levels of cognitive, affective, and physical development place significant limits on their ability to recognize, avoid, or escape abuse. They really cannot get away from it. They're likely unable to fight back against an attacker or to provide for themselves in cases of neglect. They also tend to be naive or confused by sexual abuse, which sort of perpetuates that cycle of sexual abuse. It's a secret, it's confusing, I'm not going to tell anybody about it. That doesn't help the child get out of the situation. In addition, the external resources are far more limited than those of adults. For example, if an adult experiences a rape or a car accident, they're more likely to have a place of safety to recover or a social support network to rely on for care after the fact. Children, however, do not usually have a choice regarding who they live with or who they can rely on for care. And in fact, the person who's supposed to be caring for them and the child is relying on is most likely the one committing the crime against them. So getting any sort of intervention requires an adult, and thus children are often rendered helpless in the face of sort of an overwhelming trauma. So the resource limitations of children confronted with sexual and physical abuse lead us to define child abuse as a trauma in all of its essential characteristics. Children who are abused are individuals who are helpless in the face of repeated, unavoidable, and inescapable transgressions against their bodies. A child's resources are no match for the immediate and consistent threat of a physical or sexual assault by an adult, particularly when that adult is a parent or a caretaker. So the resource limitations the child experiences in confronting the trauma are really defined by the child's life stage and yield a circumstance in which the child rarely succeeds in neutralizing the threat. Once the trauma has occurred, its presence creates a cascade of resource losses that continue through the course of the trauma, so however long it lasts, and have consequences for much longer after the abuse ends. So many psychological and social developmental opportunities and advances are likely diminished or negated as a direct or indirect result of the abuse. So this may include a loss of a normal caretaker relationship, which we know is integral for a normal child development. Resources such as food, basic care tasks, or other more complex tasks like going to school, learning language, anything like that. So these developmental requirements require contributions from the caretaker, the family, and the community. And as previously mentioned, these are likely not accessible to children in abusive situations. Recovery from the abuse requires repairing these resources. Without the aspect of this treatment, adults are likely to experience, they're still going to have functional impairment if we don't go back, and kind of address some of the problems that were created in development. So the first thing that needs to be addressed is healthy attachment. And this is definitely a resource that obviously is lost in an abusive relationship, but it's really one of the more devastating aspects of child abuse, in that the abuser is also the caretaker. It's been well documented in the literature that the attachment of a child to a parent or caretaker creates the basis for learning the essentials of living. And again, that could be a whole other grand rounds topic. But from this sort of healthy attachment and relationship, it springs effective agency, self-definition, and autonomy. It provides sufficient safety for the child to explore and learn about the world in a safe way. It also works to help increase their confidence and self-esteem. In a normal caretaker relationship, the caretaker provides a secure base, and the caretaker acts as a facilitator to the child's growing capacities in self-management and effective interaction with the social and physical environment. In an abusive relationship, especially in sexual or physical abuse cases, there's a sense of betrayal in the parenting responsibilities, resulting in a loss, a perceived loss by the victim. It's a loss of security, a loss of personal safety, restricted capacity for curiosity and exploration of the world, as the world is kind of a scary place for these kids. A loss of a healthy trajectory of effective organization, and developing a healthy set of self-soothing behaviors, or even any sort of emotional modulation behaviors. There's also a sense of loss of autonomy and agency. In adults, what we see is this kind of manifests itself in problems with intimate relationships, self-esteem, and positive self-regard. And we're going to talk a little bit more in a minute about specifically how to address this in therapy. For social and emotional development, children who are abused often come from families in which caretakers are limited in their emotional expression and interpersonal functioning. These families are usually very isolated. The adults don't have a lot of friends. They don't have a lot of positive relationships with extended family members. And thus, they're not effective in modeling appropriate emotion regulation techniques or appropriate interpersonal relationships to children. In addition, an abusive environment provides conflicting and paradoxical information about effective and acceptable rules for living. As such, children experience peer rejection because they have learned improper behaviors or improper ways of dealing with people, such as physical aggression. And children who have been maltreated tend to show difficulties with high emotions, problems with social engagement, conflict negotiation, and they expect little social support from adults in resolving social problems. They don't look to adults to kind of help mediate problems with peers. These problems continue into adolescence, and they can lead to issues such as dropping out of school, substance abuse, delinquent behaviors, and also adolescents who have been maltreated are, I think, 3 times more likely to be victims of dating violence even as teens, and they're 2 to 5 times more likely to commit suicide when compared to same-age peers. So that's quite alarming. Their risk for re-victimization increases, and in adulthood, these losses are described as lost opportunities in realizing goals in both work and personal lives. And finally, there's a loss of support and connection to the larger social community. So abused children do not often experience full and positive engagement in the community. They're likely juggling demands at home, such as the abusive situation itself or dealing with their unstable parents, peer rejection, and limited interaction with healthy adults, and feeling alienated by the community due to the secret of their abuse, especially in the case of sexual abuse. So this stigma of abuse has a strong factor in the community, as abuse of a child challenges sort of our American standard belief that the world is benevolent and we are all competent to take care of ourselves. And thus the desire to keep this illusion leads to an unrealistic level of competence in children to defend themselves. Further, as an alternative to recognizing the existence of abuse, there is certain confusion about how to intervene. So some adults just don't know what to do when they find out about it. And supporting that, recent data indicate that while 9 in 10 Americans regard child abuse as a serious problem, only 1 in 3 reported abuse when confronted with an actual situation. So that's cognitive dissonance if I've ever seen it. And it's really sad. So traumatized individuals also, they require a lot of community resources such as time, money, and effort, which I'm sure all of us know can be a huge obstacle in obtaining appropriate interventions for abused children and adults. Okay. And the last portion of the resource loss model is PTSD. So data suggests that the immediate responses to a trauma are described in the DSM diagnosis criteria, including hypervigilance, trouble sleeping, intrusive thoughts, problems with concentration. I'm sure we're all very familiar with those criteria. But over a relatively short period of time, the course of recovery progresses and the person assimilates into the experience of being abused. So the specifics of the incident are organized into a sequence of events and an evaluation of the meaning of the event and its impact on that person's worldview. In the resource loss model, like Cloytra explains, those who develop enduring symptoms they don't have the resources required to recover from the trauma, and the trauma is just greater than their need and their resources that they have to deal with it. Thinking back to the previously outlined deficits in interpersonal, intrapersonal, and community functioning, it's clear that recovery is difficult for those who have been abused. Bruin and colleagues in 2000 conducted a study evaluating risk factors for PTSD, and it was concluded that those who had low resources, i.e. past adversity, diminished mental health, a lack of social support, and low education, led to an increased risk of PTSD, and they had more severe PTSD. So for children, PTSD has been widely studied, and one of the major questions that sort of spawned this area of research is, are caretakers resources for traumatized children? The short answer is yes, but this was first examined during World War II, where it was observed that children did well if their parents were psychologically healthy themselves. So children, they used their parents as an anchor, as a social reference, to understand the meaning of the traumatic event, to understand the cause and effect in the event, experience safety and support, obtain comfort, and receive guidance in effective coping. A consistent finding in the children's trauma literature is that when exposed to the same stressor, children's reactions vary with the warmth, psychological stability, and coping capacities of the parent. Thus, if the parent is the abuser, this may lead to much more alarming and severe consequences for the child. In adolescence, sexual abuse is consistently the top-ranking PTSD-producing traumatic event. Lipschitz in 1999 found that 60.5% of inpatient adolescents with sexual abuse histories had PTSD, which was significantly higher than other traumatic events such as exposure to family violence and physical abuse. And physical abuse only had about a 28% PTSD rate, so just to give you some context. In adults, I'm sure many of you are aware of this, probably more than I am, the adult lifetime prevalence of PTSD is higher than reported among children and adolescents, which makes sense. For adults who have experienced child sexual abuse, 77% had PTSD, 45% of those who had experienced physical abuse had PTSD, while 85% had PTSD if they had experienced both. Other estimates have ranged from 69% to 73%, depending on the sample. In comparison with rates of other disorders, have identified PTSD as the most frequently occurring Axis I disorder associated with a history of childhood abuse. So, what do we do with these people when they come in? The implications for treatment often result in the manifestations of psychiatric symptoms related to PTSD, but they're also a lack of skills in the area of social and emotional competencies, like I've kind of already talked about. So the treatment approach that Cloytre takes addresses both the recovery from the psychiatric symptoms and the rehabilitation of resources and life skills that have been underdeveloped or not developed at all in survivors. The treatment program that she has, which I've used and I really like, so I'm going to describe it in detail, is a two-phase approach focusing equally on the development of resources and emotional processing of the trauma. Both of these aspects have been researched independently, and the skills training portion has been shown to have some effectiveness in treating PTSD symptoms, but just the skill building alone, this approach has been limited in its empirical support. Overall, exposure interventions have been shown to be superior to other forms of CBT for resolving PTSD symptoms, but there's consistent evidence that when a client successfully engaged in exposure therapy, the long-term benefits after treatment were found to be superior to other treatments. But when you add in the skill-based approaches, their positive gains lasted for longer, and you generally saw a complete resolution of PTSD symptoms. Thus, this treatment combines the two approaches into two separate portions: skills training for effective and interpersonal regulation, called STARE, and narrative storytelling, which some of you may be familiar with. So one of the questions that I'm hoping, well, maybe nobody will ask it now, is why a phase-based approach? And this has been shown effective empirically. There's been some controlled studies that have looked at both elements separately, combined. They've done it over and over again, compared it to medication. And what we found is that it's more effective than traditional focused trauma work. So first, the skill building portion is the initial part of treatment, and it gives clients some time to learn. So studies have shown that when coping interventions and processing of traumatic events occur simultaneously, the benefits of treatment were no greater than the benefits if just one or the other treatment components were provided. Second, it provides the client with a skill set for dealing with the emotional burden and catharsis of the narrative work. The narrative work is usually pretty intense. It involves talking in detail about the traumatic things that have happened to this person, and it usually elicits very strong negative emotions. And if the person has the skill set to deal with it, that's really what you're looking for, as a positive treatment gain, and it's a good way to show that they're on the road to recovery. Lastly, it really emphasizes, this treatment does, and the research suggests that the importance of the therapeutic relationship should not be underestimated. The working relationship between a client and a therapist has consistently shown to be the single most important factor in predicting a good treatment outcome, and that's across various diagnoses and theoretical orientations. So spending time dealing with less intimate, less invasive issues such as skill building allows the survivor to build a positive, nurturing, comfortable relationship with an adult, which might be the first time in their life that they've had that. And it also allows for an easier transition when you go into the narrative portion, so the person feels comfortable sharing these things with you as they have a very positive relationship with the therapist. Okay, so let's talk a little bit about STARE. So the first part of treatment follows the trajectory of human development in the competencies that are outlined on the slide. So this aids the development of agency, and it allows the client to know what one feels and then to use those feelings as a guide to action. The development of agency allows for successful communication with others, leading to connections with others, which we know is a good thing, and something which is often lacking in victims of child maltreatment. So the skills of identifying feelings, managing and expressing emotions, enhancing assertiveness, and increasing flexibility in relationships all build on each other to make emotional and social resources that are vital for full recovery from trauma. The treatment initially focuses on emotional competencies and then moves on to interpersonal functioning. So emotional competencies are the ability to identify, monitor, manage, and express emotions for specific functional or adaptive purposes. As previously mentioned, these competencies are disturbed by abuse, so addressing them in therapy is essential for recovery. And these competencies, it's a lot to cover, and it's divided further into three major areas: emotional awareness, emotion regulation, and emotionally engaged living. Emotional awareness is sort of a prerequisite to effective emotion modulation and effective living. Whether we're aware of our emotions or not, they guide our decision-making and our actions. They inform others and sometimes ourselves about who we are. So awareness of emotions is the first step in self-knowledge, self-regulation, and self-direction. We cannot modulate emotions without first being aware of them, and it's essential that a client learns how to accurately identify and label their feeling states. This is accomplished by using techniques such as self-monitoring, psychoeducation about emotion regulation, and sources of disruption, so letting the person know how it got disrupted. And these interventions target a common phenomenon that we've seen in survivors of child maltreatment, which is now called alexithymia. Emotion regulation. So emotion regulation is the idea. It was generated from Marsha Linehan, which many of you are probably familiar with her name. She's usually associated with dialectical behavioral therapy, which is a type of therapy often used for clients who are highly emotional and chronically suicidal. And these people have problems with emotion regulation such that they experience a rapid and intense emotional increase from their baseline and then have very difficult times coming back to baseline. And notably, that's what I found in my master's thesis, so it kind of goes along with the literature. And DBT operates on the idea that clients should be prepared with skills to deal with emotions, with intense emotions, rather than simply just being carried away with them and sort of reacting to them. There are three systems that should be addressed in this portion of treatment, and that includes physical or physiological management, so things like deep breathing, exercise, stress management. Cognitive strategies such as self-statements, reframing of upsetting events, and attentional control. And the third one is behavioral management and social support. So asking for help, talking with others when needing support, talking with others about one's feelings. The goal is to strengthening these coping strategies to create a well-integrated set of coping skills so that physical sensations, thoughts, and behaviors influence one another and work together toward well-modulated emotional experiences. Notably, these strategies include modulating negative emotions, but they also include dealing with positive emotions, which is something that is not talked about very much in the literature, but it is important to address it in session, as positive emotions are often really confusing for people who have been abused. They're uncomfortable, they're really not sure what to do with that, and sometimes if they're feeling something positive, it feels dangerous. So it's also important to take those emotion regulation skills and apply them to positive emotions as well. Finally, for emotionally engaged living, so for many survivors, the only alternatives to living a painful and sort of out-of-control life, using tools such as emotional avoidance, social withdrawal, having limited pleasure in daily activities, and they're really pretty severely limited, in the actualization of their potential. So this portion of treatment includes encouraging clients to identify positive goals, to articulate their wishes and desires, and then really helping them realize these goals and desires. So the concepts of distress tolerance, which is another Linehan contribution, and accepting positive emotions as guides and planning to action are really emphasized in this portion. Distress tolerance can help a client achieve the inevitable uncomfortable feelings that go along with making and attaining goals, and really some of those uncomfortable feelings that go along with making changes in their life and feeling more comfortable with being happy and not being unhappy and traumatized. Okay, I know we're running a little low on time. The second portion of STARE deals with changing relationship patterns. So this is obviously more of where my knowledge is for traumatized people, with traumatized adults, but problems with relationships are often what bring people into treatment. You know, the husband or the wife or the girlfriend or the boyfriend, they tell them there's something wrong with you, you need to go seek treatment. And as you can probably guess, that these problems stem from either feeling too much emotion and reacting to it, or not feeling any emotion and not really knowing what to do about that. This portion of treatment seeks to identify abuse-related schemas and thus change relationship patterns. Abuse-related schemas may define or support negative feelings, and they can be hard to change. So some of those schemas may include to be in a relationship means to be abused, or abuse is how you show love, or abuse is one way of attaching. And once these schemas have been identified, it's important to change them into more positive, healthy schemas using CBT techniques like reframing negative thoughts, identifying negative thought patterns, or cognitive errors. Making more positive schemas are the tools for creating more positive relationships, and are used as a positive treatment gauge, so you can kind of tell how the person is doing. Finally, schemas are effective tools for working with multiple relationship difficulties, in that the survivors are going to have to be changing gears. So how you deal with your boss isn't the same way that you deal with your husband, and helping them to resolve the conflict between the old schemas and the goals from the new schemas. Something to keep in mind. The second portion of treatment, the major portion of treatment, is narrative storytelling. And this portion of treatment targets PTSD symptoms, emotion regulation difficulties, and interpersonal problems. But mainly it's been shown effective in resolving some of those PTSD symptoms. So the first goal involves the retelling of the traumatic event with the purpose of confronting the fearful elements of the experience and dissolving the power of that memory to elicit fear. And the second process involves appraising the meaning of the traumatic experience in the context and evolving life story and integrating it in a more positive way. So I think this maybe might be a good time to just give a little bit of history about PTSD research and exposure therapy. So this comes from the work of Edna Foa. So I'm sure a lot of you are probably familiar with her work. And she works in this area, but the first sort of documented efforts in resolving PTSD through emotional processing of traumatic memories were made by CBT psychologists working with combat vets in the late 1970s and early 1980s. These therapists noticed that the sights, sounds, and smells associated with traumatic events or that occurred during the traumatic event were not in isolation frightening, but the maladaptive association that the victim had made with these sensations was quite frightening. So studies began using footage of combat situations to induce and measure fear responses in veterans. And what they found was that, indeed, veterans responded with intense fear. They had affective responses, increased blood pressure, increased epinephrine in their bloodstream, and much more than veterans who had not developed PTSD. So these results informed treatment as the therapist worked with clients to resolve useless and maladaptive reactions to decouple the sensations from the stimuli. So by exposing the client to the stimuli in the absence of a real threat, the clients would experience a decline in the fear reaction, and the stimuli theoretically loses their threat, loses their fear response. The research also noted that fear reactions of similar strength could be elicited simply through evoking a memory of the traumatic event. So increased heart rate, blood pressure, muscle tension, all measurable aspects of fear reactions could be induced simply by thinking about the trauma. This led to a reformulation of PTSD as a disorder of memory, and the process of habituation that had been previously applied to the actual external stimuli were adapted so that the therapist could use it in an imaginal exposure. The therapist would facilitate the client generating an image of the trauma in full or sufficiently detailed and for a long time, such that the client's fearful reactions to the memory would diminish and PTSD would resolve. This, however, has not been confirmed in the empirical research, as usually if you just do imaginal exposure, the PTSD does not completely resolve. So once these findings came out, and this was like in the late 80s, early 90s, about imaginal exposure, a line of exploratory studies started looking at the neurobiological basis of enduring fear memories that looked at brain structures such as the amygdala, which is the center of learning and unlearning fear reactions. So early research found that EEG patterns that were thought to diminish in the areas related to fear response, they showed an overall reduction in neuronal activity, but that the cells that were identified as being specifically related to the learned fear do not extinguish. So this fear reaction, as represented in the neuronal activity of the amygdala, did not go away. This phenomenon has been described as the indelibility of emotional memories. So the implications of these findings are that traumatic memories can never be entirely freed of the overwhelming fear in which they had been encoded. And this is substantiated in many empirical studies, namely Boutin and Schwarzentrubler. I thought I was going to say it, but I didn't. This indelible aspect of trauma has provided an explanation for the diverse observations that have been made about trauma over the years, such that memories can be activated or reactivated with sufficient cueing or under circumstances of sufficient emotional power. And this is consistent with observed relapse of PTSD symptoms as is seen clinically, or if a survivor is presented with emotional or physiological environments similar to the circumstances of a trauma, recovered memories, the emergence of PTSD among elderly people who have been confronted with a chronic illness or with mortality, such as World War II vets or Holocaust survivors. This indelibility also explains the high relapse rates for PTSD and combat vets, though many new studies are likely to address this with returning vets from Afghanistan and Iraq. So this treatment attempts to address this indelible aspect by using habituation not only to address fear, but also shame and guilt, which are commonly felt by survivors of abuse and are not addressed in most traditional PTSD exposure treatments. Shame and guilt are also the best predictors of relapse in PTSD. Thus, by examining narratives that address these feelings, survivors are less likely to relapse after completing the narrative portion of treatment. So during the narrative portion, The survivor is asked to recall the memory several times in great detail, and it is expected that through the repeated telling, the associated fear reactions will diminish and the memory will become more organized and internally coherent, so that the questions about the facts of the matter, what happened, when did it happen, how did it happen, are answered as clearly as possible. And the therapist then works to identify interpersonal schemas, themes, and core beliefs that are consistent across the telling of the memory or consistent across a set of memories, however it comes up in session. The therapist helps the client compare the past and the present, as well as integrate what they've learned in the previous session, which was skills, the previous portion of treatment, and how they're going to move on from this. How do they integrate it with who they are today? Again, the narratives focus on fear, shame, or loss, and usually how it's divided is you do narratives only devoting to fear, narratives only devoting to shame, and the narratives devoted to loss. Post-narrative grounding techniques are used to orient the client to the present, and they're also encouraged to use a lot of those emotion regulation skills and coping skills they've been taught previously to manage their strong emotions. So the clients practice new behaviors, they practice emotional awareness, they contrast the present with the past, and redirect their attention and energy to the present. So I think I'm right on time. So in conclusion, this will be short. Child maltreatment is a pervasive problem with severe consequences that span the survivor's lifespan. Psychotherapeutic interventions have been shown efficacious, and successful interventions include a positive therapeutic alliance, addressing skill deficits, and exposure to traumatic memories via narrative techniques. So, any questions or comments? Thank you. Just individual, yeah, and it is. It's 12 sessions, and each session has a different topic, and it's also you have to kind of take into account some clients might not need all of the topics, some might need more time on them, but yeah, each session has a different topic in one of the emotional competencies.
Is it available?
It is. So it's an electronic resource through the library. You can go and search on the Health Center library, and they have it electronically, so you could download the session out. I don't think they have the session outlines, but the chapters that go along with it and how you would set up treatment. Yeah.
And what about the narrative storytelling? That's, I assume, is more open-ended and patient-specific.
Yeah, it's definitely going to be driven by sort of their hierarchy of traumatic memories. And then the themes that you're just going to have to build from them. But hopefully by then you have a pretty good idea about what the narrative should involve.
Yeah. Just to follow up that, it's going to be very different if there's one traumatic event versus a repeated thing.
Yes.
Maybe even in severity.
Yes.
How do you deal with the more repeated kind of things?
Well, I can tell you how I did it, how I was instructed to do it. In graduate school, I worked with a client who had had years of abuse. And what we did was, once we got through the skill building, he was sort of like, we don't need to talk about maybe the lesser events. Let's talk about these ones that I just can't get out of my mind. So we kind of prioritized the ones that bothered him the most and dealt with those. And really, once you've hit kind of the big guns, the smaller ones will kind of, he was able to deal with those on his own. So that's how we did it. That's how I was instructed to do it, is just have the client pick the most distressing memories and work with you on that. And then really they have the skill base to do those imaginal exposures on their own if they wanted to. So.
Is there any data on the success rates of these techniques, and then more specifically whether that success is affected by the duration after the therapy?
Sure, so that's a good question. So Cloitra's treatment is usually about 80% effective, which is pretty good, I would say. I've been pretty happy with that. And it's been shown that you can do it with people who have been abused 15 years ago, 20 years ago, 5 years ago. That doesn't influence how well they do in treatment. So that's a good thing. I will say that for kids, the treatment that has the most kind of effective and highest success rate is trauma-focused CBT. That's from Esther Deblinger. And they have an online resource resource if you're into that. You can go and do the online training, and you'll be certified in it by the time that you finish the training. So if you're interested in doing more child trauma work, if you just Google trauma-focused CBT, they have a whole online series and lots of resources for clinicians and for survivors.
When I think about the narrative, I'm sort of hearing you almost say this, and I presume it's because you are saying it. When I think about Pennebaker's work of having Holocaust survivors that they had to talk about the details and they had to have the emotions there together. And either one of them separately didn't really get it.
Right.
Is that the same here with this?
Yeah, exactly. Yep, you have to have both. And, it might take you a couple tries to get to both. It can be hard just to sort of figure out what the facts were, and then you have to build in the emotion. And that's why I usually have them tell the same narrative over and over and over, and every time you ask a different question. And a good example of this, if you're looking for kind of the technique, there's a video on the ABCT website of Edna Foa doing a narrative. It's with an actress, I should say, at one of the ABCT conferences that I went to a couple years ago, and she has her tell this. It's a 45-minute video, I think, and she goes through the same thing, I think 6 or 7 times, and every time Dr. Foa asks her more questions, gets more details, how were you feeling, and then really sort of teases out all the different emotions that were felt. But if you give yourself enough time, you can get to the facts and the emotions, but that you really do have to get to both, yes. Anybody? Okay, thank you.